Hi, welcome everyone. Welcome. We're so happy to have you here today. We have our guest favorite ED physician with us today. So can't wait to introduce her, but we're going to be talking about alcohol use disorder. It's an update, but it's a deeper dive. We did last year's training and we kind of touched upon it, but we're really going to go in depth because we keep hearing from you. This is something that you requested. So we aim to please here at California Bridge. Please let us know you're here. Type in the chat what site you're from and how long you've been working in the ED. We don't care if it's 2 weeks or 4 years. We want to know who's here. So as people are doing that, I am just going to introduce myself. I'm Sherry Cisneros, the Navigator Program Director, and we put some lovely trainings for you, and we always do, but please remember to complete the evaluation at the end of this training. We always want to get feedback from you for future topics. As people log on, you know who we are. We want to know who you are. So keep typing in the chat and hello everyone. This is exciting as people log on. We always like to see who's here with us. And hi Nash, I feel like I know everybody here. Wow, this is really neat. Lots of old friends here as well as some new ones. Hi Roger. I remember Roger at orientation. So we're really getting a lot of people here. Jenny, we just saw you a few weeks ago. So this is exciting. Again, there's some old friends and new friends too. So I'm really liking our audience today. So again, we're going to be talking about alcohol use disorder. And we do share our information through Creative Commons. And so we will be sending out the slide deck in an email. So you will receive a post-event email. So welcome, and we want you to get the best experience today. So please make sure that you're connected to your computer. And I'm gonna admit I'm one that always forgets this. Use the chat for questions and address to everyone. Do not just send it to host and panelists, because I do that, and don't be like me. Be better than me. So please make sure it's to everyone, because if you have a question, people definitely want to know. Closed captions should be available on your screen. And again, we will follow up if any technical difficulties, but I don't anticipate any. These are our objectives for today. We hope you just have a understanding and prevalence and the harms of AUD, describe alcohol withdrawal symptoms. And I'm really excited about this portion because I know a lot of you had questions. Verbalize understanding of treatment options and understand the difference between opioid use withdrawal versus AUD. So again, I'm really excited to announce our speaker in a second. And so we just always like to, I always like to remind what our California Bridge model is. It's low barrier treatment. That's your clinical champions out there administering the medications. And our navigator's role is more of the connection to care and a culture spreading the culture of harm reduction. So we're going to take a poll right now. Aiden's going to pop it up on the screen. What is the most common SUD in your ED right now, today, going on? We want to know what it is. Is it alcohol? Is it opioids, fentanyl? Is it methamphetamine? Or is it polyuse? We have a lot of that going on too. So we kind of just want to hear from you. We're going to take a minute for you to complete the poll. And again, right now, not what happened last year, not what happened, we want to know right now in March, what are you seeing? Because, it does go in waves, you guys. Definitely it goes in waves. I think another minute, and then we're going to reveal our results. We just kind of want to know what's trending. We love our trending topics, right? So we want to know if we're on the mark with this one, with this training today. Again, welcome everybody. All right. Has it been a minute? Time goes by fast. So yep, we are on the mark, Alicia. Look at this. Alcohol, 55%. I like it. So we're right on trend. Opioids comes a second, methamphetamine and polyuse. Seen a lot. Polyuse is second. Yeah, I've noticed a lot of our navigators just saying that, polyuse has been really predominant lately. So that kind of is definitely with the trending that's going on right now. So without any further wait, I am so happy that Dr. Alicia Gonzalez can join us today. She's in the middle of a move. So, so she, this just shows how important and supportive she is of our Navigator program. So again, we love Alicia too. So she's with us today. If you don't know Alicia, she's an emergency physician in Santa Maria, San Diego, and Brawley, California. She's an opioid stewardship physician champion, Dignity Health. She's an implementation leader and director of our clinical training here for California Bridge. I asked Alicia for an interesting fact, and this was funny because she told me, do not buy her cake. She's not a cake person. Like, you're trying to win her over.
Yeah, no cake.
That was something she wanted to share. So Alicia, I give it to you, and I know you're going to enjoy this and make it wonderful. Welcome, Dr. Gonzalez.
Thank you. I hope that all of you, I can't believe there are 120 people on this call. This is amazing. And I saw some people like, I've been at my job 2 weeks, and some people like 16 years doing substance use work. So I want to honor, before we begin, that for some of you, I talk fast. And if you've ever seen my presentations, we do a lot in an hour. So if you feel wholly overwhelmed, that's okay. The goal is to take away a couple of things every time and review the information multiple times. That's my advice to you. And if you're a seasoned person, you'll probably get something different this time than you did last time. But hopefully our goal is to give you some tools to better understand alcohol use disorder, specifically when we're seeing patients in the emergency department in the hospital. Because one of the main things I see is a lot of confusion with opioid use disorder and treatment compared to alcohol use disorder and treatment. And as we just saw, everybody knows there's a ton of alcohol in our areas. On the next slide, we actually have a nice little graph showing this is the prevalence of substance use disorders by type. And any substance in general is pretty high, but alcohol is number one, just like in our poll. So it definitely supports what all of you are seeing out there. We talked about this. What substance kills the most people? Anybody know? Okay, go ahead and click the button. We'll give away the surprise ending here. But the answer is that alcohol-related deaths are actually higher than opioid overdose. These are a little couple of years separated. And so we wonder now with fentanyl, thanks for that, Melissa, that maybe fentanyl is actually higher. But the point is, with alcohol, you can die from a whole lot of things. So if we look at the next slide here, compared to other substance use disorders, when we have studied them, alcohol causes the most harm. And this paper that we're looking at a graph for came from the UK Advisory Council. It was published in 2009. And they looked at a really long list of ways that you can die or sustain harm associated with your substance use. And this is a very, very long list. It wasn't just necessarily death, but it was, cirrhosis, liver failure, seizures, heart disease, stomach ulcers, unwanted sexual activities, all kinds of things that can be associated. And alcohol by far ended up causing the net most harm to our patients. So remember, death is definitely an outcome we're trying to prevent. So are all these other terrible things that happen to people, and alcohol scores the highest for being able to cause those harms. What's super sad is that we do have medications to help treat alcohol use disorder, and only 1 in 10 patients are even in treatment, like any kind of treatment, whether it's Alcohol Anonymous or therapy or whatever. And only half those patients, so 1 in 20, are on medicines for alcohol use disorder. This is horribly sad. There's so many patients out there who could use these meds. People don't even know about them. And I'm going to be honest, a lot of doctors don't know about them either. So one of your greatest roles as a son can be introducing the concepts to our clinicians, like, hey, did you know that there are medications to treat alcohol? What do you think about Naltrexone, Gabapentin, et cetera, in this patient? And we'll talk about those in a second. So On the next slide, when we see alcohol, we don't always just, same with opioid use disorder. We don't just see people come in saying, hi, I'm withdrawing from fentanyl, right? They come in, they say, I have an abscess. I might have a skin infection. I might feel like I have the flu, and they're not comfortable talking about what's really going on. Alcohol is the same. Sometimes alcohol use disorder presents as a trauma, right? Like drunk driving causes all kinds of accidents, horrible accidents. And those patients come to the emergency department. They might come in with vomiting. They might come in with altered mental status. They might be in alcohol withdrawal. They might be having a bleed from their intestines because of their chronic alcohol use that led to cirrhosis and makes them really prone to bleeding. They can have heart failure or kidney failure associated with chronic liver disease that comes from alcohol use disorder. So we don't always see people with alcohol use disorder coming in saying, hey, I drink a lot and I'd like help quitting. That is almost never what happens, literally. But we have to be very adept at recognizing that all of these other presentations can be caused by alcohol use. I do think that this one, more than opioids, we tend to see people with random variety of problems, which it takes another step of questioning to figure out the real root cause is alcohol. Whereas I do think that with opioids, it's a little bit more simplistic sometimes, like the abscesses, it's easier to remember to ask about injection use, right? Alcohol can be a little bit more nuanced. When should you worry about patients? Well, first of all, everyone drinks alcohol, right? So on the next slide, we have a list of when is that alcohol use worrisome? Because I drink wine with my dinner too, right? Like, do I need a substance use navigator? Probably not. But is somebody heavy drinking or binge drinking, which is defined as about 4 or 5 drinks per occasion? It varies a bit based on size and gender. But in general, 4 to 5 drinks in one sitting. And then if that person has any heavy drinking at all, even if they binge drunk, let's say they went out and partied 3 times in the past year, that alone is enough to trigger just the questioning, just to use the audit tool to screen patients. And so that's not it's just a helpful way to screen in on, do we want to screen patients? While we know that screening is helpful overall, I want to emphasize that in alcohol use disorder, using formal screening tools is super evidence-based. We have tons of evidence that shows us these are super helpful. You hopefully have already heard of the SBIRT. I know that there was an awesome training going in more detail about this for all of you recently, but like for my 2-week employed sons out there, you might be newer. Please reach out to any of our son mentors. They can get you a link so you can watch that training and do a little bit deeper dive. But basically, SBIRT stands for screening, right? So I mentioned, maybe somebody mentions, oh yeah, I totally like blacked out last weekend when I was out with my friends. Woo, pause. Let's do a little deeper screening and ask some more questions. Based on the results of that, you do a brief intervention. That could be harm reduction or whatever it needs to be for that individual, and then referral to treatment. That's kind of the California Bridge model, right? We love doing that warm hand up, and that's where our navigators are one of the most important part of our work. There's this really, really beautiful handout that you can download. On the reverse side of it, it actually has a screening tool for you. So you can print this to use it as an infographic for your patients. We can always get you guys the link, and yes, you will have access to the slides. A lot of people are already asking, don't worry about that. But you can use this. And then on the back, it has a score for audit, which is one of the ways you can check people's alcohol use disorder. And you can use this pyramid to show them like, hey, look, did you know that 40% of people, want to abstain and they're not drinking, but 35% are low risk drinkers. Even being low risk is a risk, right? So it's important to be able to have that conversation. This is a great tool for you. What do you need to know though, as the navigator? You need to know how to use an SBIRT, especially with alcohol use disorder. Again, this is evidence-based. This is a really important step. Lots of studies have shown that this is effective. So please, watch that training. We can reduce stigma, as always. This is not a surprise. And frankly, I think our navigators lead the charge in this way. But remember that, patients are going to use substances. Our job is not to say, you're terrible, don't ever do that again. Our job is to say, hey, did you know that could be dangerous? And I'm worried about your health and your wellness. And can we just talk about ways to keep it safe? And we'll get there together. And in that conversation, utilizing harm reduction techniques. We would love for no one to drink, have teenagers have sex and not use drugs. I would love that. That's not realistic. And so how do we have realistic expectations and help our patients stay safe no matter what choices that they make for their own life? And then offer them support, offer them hope, It takes a lot of tries sometimes for people to be successful, right? Relapsing is a part of the process. Addiction is a chronic relapsing disease. People go in and out of it before they're successful. Tobacco, 7 tries. Takes 7 tries for tobacco, for example. So give people hope. Hey, you've tried once, you can try again. You never know when the right try is going to be. And that's a huge role that we play. So looking at the treatment, this is the part that I'm the expert at. The rest of that, honestly, is just a recap because you all probably could teach me a thing or two about screening and counseling on harm reduction. But I want to talk to you a little bit about medications for alcohol use. And on the California Bridge website, we have a nice picture of it here for you. We do have a clinical guide for our clinicians talking about the meds that I'm going to talk about. So if you have a patient that you think would be great for some of these treatments, I recommend just referring your docs to this. I don't think that the Navigator's job is to educate our physicians on clinical stuff because they want to know so many things that would be hard for you to learn and describe to them. But what you are awesome at is opening the door to them. This is possible. Hey, can I print this for you? Did you know this is a thing? There's a training on the California Bridge website. Maybe you could watch it. I mean, it sounds like it's really great. ... Right? That's an awesome role for you to play in helping our clinicians find this information. And I want to also point out, this is a separate protocol, right? You don't see the word buprenorphine anywhere on here. And that is because not all drugs are equal. Not all withdrawals are equal. Alcohol withdrawal is not opioid withdrawal, and alcohol treatment is not opioid treatment. So in our protocol that was on the last screen, the very first step is to treat withdrawal. So I want to take a beat to talk about what that is. Opioid withdrawal, we know. That one we know. You stop using opioids, your body goes into withdrawal. Physiologically, it's the same concept. Like, you use alcohol regularly, your body builds dependence. So to feel normal, it needs alcohol in your system. Totally different receptor, okay? Totally different receptor, totally different substance, but similar process. Your body builds dependence. And then if you don't have it in your system, you withdraw. One of the critical differences, though, is that alcohol withdrawal is deadly. It is a life-threatening medical emergency. Opioid withdrawal is awful. And we know that the mortality risk of patients who, overdose is obviously very high, et cetera. But opioid withdrawal in and of itself will not kill you. It is painful. No one likes it. It is god awful. And I don't want anyone to go through that, but they won't die. They'll eventually just kind of wash all the way out of their opioid. Alcohol withdrawal, left untreated, kills people. So this is a huge, huge difference. And why is this one so much more deadly than others? I can't really tell you why. That's just how the body reacts to it. But what happens is that in early withdrawal, you see people get kind of like anxious. They aren't sleeping very well. They start having nausea, maybe some belly pain. Then they start to get high blood pressure. Their body, they can get like almost low-grade fevers just from their body having such a high metabolic process, which is it's just very unpleasant. But the problem is that after a couple of days, they can go into full-blown hallucinations. They can look psychotic. They can have seizures. Yeah, thanks for that, Roger. They can have alcohol withdrawal seizures, which kill people because those seizures are very hard to treat. They require very high doses of the medications we use, like benzodiazepines. A lot of you know the word Ativan, right? It's a common one that we use is Ativan. People can get super agitated. And then over several weeks, they can even go into something called Wernicke-Korsakoff, which is associated with a vitamin deficiency, and it can cause permanent brain damage, is sort of the bottom line here. So really dangerous, definitely deadly, which is why the first part of our protocol talks about treating the withdrawal. So since it's a life-threatening emergency, the treatment for withdrawal there are a couple, but the main ones you're going to see us using are benzodiazepines or phenobarbital. So phenobarb, you'll hear us talk about phenobarb all the time. Benzodiazepines, benzos, good examples are lorazepam or Ativan, alprazolam or Xanax. You might see us using Versed is another one, Valium, there's a whole bunch. Clonidine, no. Librium, yes, but not so acutely in the hospital. It's a little bit more long acting. So in the hospital, when someone's in withdrawal, you're mostly going to see us using short-acting benzos and I'm saying brand names for your awareness because everyone says them, not because I'm loyal. No one's paying Sherry or me to say these brand names, so don't worry about that. But people will use mostly Ativan or Versed. Those are the two that you're going to hear them using. Or phenobarb. We like phenobarb because it's longer acting. So if somebody's trying to go into treatment, we will use that one. Benzos are lethal. Yes, they are hardly lethal compared to alcohol withdrawal. So we do the right thing. Some patients will be so sick from their withdrawal, their doses of benzos have to go so high, we literally have to intubate them to keep giving them medication because they do stop breathing. So it's a very, very serious thing. And is there a different protocol for patients under 18? No, but thank you for asking that question. All right, so that's the withdrawal piece. Really different than opioids. Bupe is the only answer that we usually talk about. It treats the withdrawal and is the treatment, not so for alcohol. Withdrawal is its own thing. And buprenorphine has no place in this lecture. It doesn't treat alcohol. So benzos or phenobarbital. Okay, next slide. Other best practices, things you should be aware of that you can talk to patients about as well, especially as they're looking like getting better and looking to leave the emergency department. Most patients who drink alcohol are malnourished. They don't get enough nutrients. They have a really poor diet because they drink most of their calories. They're too full to eat, honestly, most of the time. And so they have a very sugar heavy, carbohydrate heavy diet that doesn't involve like fruits and vegetables, for example. And so taking a daily multivitamin is a really important part of the process for them, encouraging hydration and nutrition. And then in the clinical setting, what you'll see us do is very frequent rechecks because we don't know if the person's getting better yet or worse yet, and they can tank really fast. Early withdrawal, you have a lot of time to, treat them and watch them, but people who are in really severe withdrawal, they're literally have been patients where I have stood at the bedside and had the nurse had a giant syringe full of the medicine. And I say, give 2 milligrams. And I just stand there and wait. Nope, 2 more. Nope, 2 more. Nope, 2 more. Depending on how sick they are. So you'll see a huge variety in what that looks like. And then other best practices are going to be what we're going to talk about in a second, which is medications for addiction treatment for alcohol use disorder. I want to reiterate again, you're not going to see the same medicines on these slides as you do for opioids. I saw some questions in the chat about clonidine. Clonidine is for opioid use disorder treatment. It's not for alcohol use disorder treatment. So different process. I know it's confusing, trust me, but you can always print out that clinical protocol just to highlight the meds that are on there to remember which ones go with alcohol. So the FDA has agreed that the medicine naltrexone, there are 2 others, disulfiram, acamprosate, there are a couple of others also, but the main one I'm going to talk about today is naltrexone. And then off-label use, but widely accepted and not like at all cutting edge or weird or, experimental, is to use gabapentin. So even though it's not FDA approved, it is considered a standard of care and absolutely fine and usable. So we're going to talk about those 2 medications specifically, because for us in the emergency department, this is really where the money's at, is those 2 medicines, naltrexone and gabapentin. Naltrexone. So I can't see anybody, but if I said, how many of you have heard of naltrexone? I don't know, a lot of you would raise your hands, but if I said, how many of you have heard of Vivitrol? I feel like a lot of you would raise your hands. Ready? Vivitrol is an injectable long-acting naltrexone. So the generic medication is called naltrexone. We have talked many times, even when I've been with this Sun group before, about challenges to getting injectable naltrexone into your patients. And so I have good news for you, which is oral naltrexone is super cheap, and super readily available. And so in this setting, when we're talking about alcohol use disorder treatment, I just prescribe the generic naltrexone oral when I discharge patients home. So really, really good thing that we can do. We all love the idea of a long-acting injectable, but it doesn't have to be that. Why naltrexone? What does it do? It prevents patients from returning to heavy drinking by helping to treat cravings. So just how buprenorphine helps with opioid cravings, naltrexone can help with alcohol cravings. And we have seen that the number needed to treat, if you remember for opioids, you may not, but it's 2 people to maintain them in treatment at 6 months. The number needed to treat for naltrexone to prevent return to heavy drinking is 12 people. I know that sounds like a lot more. Those are actually both really good numbers. There are things we do in medicine where the number of people that you need to treat to make an impact is like several hundred. So for us to have the number of 12, it's very, very good evidence. It's really effective to use this in an office-based setting or from the ED, because as I mentioned, easy to get it, oral medication, super cheap, like NBD, super easy to get. So it also, what it does is it's an opioid antagonist. This is where people, I think, get really confused about why are we not talking about opioid treatment? We're talking about alcohol, but the same medicine. What it does, both alcohol and opioids stimulate dopamine. Dopamine makes us feel awesome and super good. And we want dopamine, the reward center of our brain. But there are multiple receptors in our body that activate dopamine surge, okay? Naltrexone blocks the actual pathway, the dopaminergic, the dopamine reward pathway, such that you just don't have as much of that craving for alcohol. So even though it's going to act on a different receptor, the way that it affects cravings is similar to how buprenorphine might do that with opioids, except bup is keeping you from going into withdrawal with opioids. Naltrexone for alcohol is stopping that dopamine reward system. So just remember, these are different medicines, for different reasons, but the outcome is the same, which is they both help treat cravings for different use disorders. So naltrexone decreases cravings and leads to less heavy drinking for patients with alcohol use disorder specifically. For primary doctors, this is probably the most realistic thing that they're going to put patients on, because they can't get injections in their clinics either. So it's really simple when we start it from the hospital, because they can easily stay on it. There are two forms, as I mentioned: oral, which is going to be on the next slide. I show you this, but 50 milligrams daily is the oral dose. That's what PO stands for. The intramuscular injection is 380 intramuscular monthly. That's the Vivitrol that everyone's always asking about. But realistically for us, we're talking about 50 milligrams oral daily. And I usually send patients home with a month, honestly.
Alicia, we have a few questions about the Vivitrol. Does it make the patient sick? I've seen several questions about that in the chat.
No, the medicine that makes patients feel really sick is a different medication. People call it antabuse all the time, but it's a different medicine. So it will make a patient sick who is trying to take opioids. So I do want to say that, and that's going to be on if you want to click to just the next slide while we keep talking. You should not use naltrexone in a patient who is using opioids either recreationally or buprenorphine or methadone as treatment for opioid use disorder, because this is an antagonist. It's a turn off on the same receptor that we're trying to turn on with buprenorphine and with methadone. So we don't want to use this medication for anybody who's exposed to opioids. That will make them sick. That would make somebody feel sick. It would knock them into withdrawal, right? It's like Narcan. It's like long-acting Narcan. Think about it that way. But in a patient who has alcohol use disorder, it should not make them feel sick. I'm glancing through. Oh, as soon as somebody comes to the ED and withdrawal, I'm starting them on naltrexone. Well, when they go home. So step one, stabilize the withdrawal. Always don't involve any other meds, stabilize the withdrawal. Then once they're not withdrawing anymore, we can start naltrexone right away. John, for some people, naltrexone is a long-term med. It really depends. That's not a decision we're going to make in an inpatient setting. Similar to buprenorphine, right? Is buprenorphine a forever med? Yeah, for some people, but not for everybody. It just depends. And so I don't try to tell patients this is forever or this is short term. I say, I'm going to start this and I want you to see your doctor to talk about what you should do going forward. So don't worry about making those decisions in the acute hospital or inpatient setting. And then the oral medication, Tracy, to your question for naltrexone, I'm being careful not to say Vivitrol, because again, Vivitrol is only the injectable and it's only one brand. There are multiple. Naltrexone oral lasts about 24 hours. Naltrexone injection lasts for 30 days. I think that's all the main things. For alcohol use disorder, we don't have to wait. No, you do not have to wait. Great question. Yes. So for patients who have opioid use disorder and are getting started on naltrexone, traditionally they have had them wait to start that medication. You're absolutely right. For patients who are alcohol use disorder and starting naltrexone, you don't have to wait a week. And that's because naltrexone and Narcan, right? So same, it's just long-acting Narcan. Naltrexone and Narcan and any opioid, bup, methadone, heroin, fentanyl, those are all trying to attack the same receptor. Alcohol is separate. Alcohol likes a different receptor than naltrexone does. So you're not worrying about this precipitated withdrawal thing. That's not what's going to happen. Yes, patient can walk out of the ED with a prescription. Great. These are such good practical questions. Oh, thank you, Rosalind, setting me up for this slide that's already on here. Yes, you cannot give naltrexone to patients who are, it's like I paid you $5. I'll send it to you later. Patients who are currently using opioids, like we mentioned, but also you don't want them to have acute liver inflammation, meaning today. Acute means now, not like chronic being long-term, right? So it's the medical word for right now. We don't want somebody to be having hepatitis. So usually patients in alcohol withdrawal, because they're so sick, they do get blood work done. Unlike opioid use disorder, right? We can do that from the lobby. We're not treating alcohol withdrawal from the lobby. Remember, very, very different. Those patients are sick. They need an IV and a bed and a nurse watching them and a cardiac monitor. Like, it's a very, very different process. And so, those patients will have labs done, and in their labs will include what we call the liver function studies. And it is common for patients to have chronic liver disease if they use alcohol regularly for a long time. That's not what we're talking about. We're talking about right now worsening of that. So if they've got a little bit of liver disease long-term, a little cirrhosis, but it's not acutely decompensating, meaning today they're not really, really sick from that, usually we can still start naltrexone. But it gets metabolized through the liver. You have to have a working liver. So if their liver totally doesn't work, then we shouldn't be using naltrexone. Hopefully that was enough specifications. Okay, cool. There should be no reason why a doctor would be opposed to starting naltrexone. It's not a controlled substance. So that's a really nice thing. There's no, special DEA anything. It's just a regular old medication. All right. I want to keep going. And then I will keep coming back if this is where we want to talk more. And yes, it can't proceed. There are other meds. I chose to pick these two because they're the two that we feel are the best for our setting. Gabapentin. Hopefully, I wish I could see all of you. Raise your hands. Have you ever heard of this medicine? And you probably have. A lot of patients who have chronic pain are on gabapentin. Gabapentin is a nerve pain agent. It's really good for neuropathy. And so a ton of patients end up being on it. Oh, yeah, lots of yeses. Okay, good. So you're familiar with this medication. Cool news, gabapentin can treat mild refractory alcohol withdrawal. It also can be used to decrease cravings for alcohol use disorder. So what is elegant and beautiful about gabapentin is that we can use it to treat people who are in withdrawal, and they can just keep taking it to continue treating their alcohol use disorder even after the withdrawal's over. This is like buprenorphine, right? Buprenorphine takes you out of withdrawal, and then you stay on it to stay out of your opioid use disorder. So similar process. And yes, it is also a medicine that is sometimes used for seizures. You can see how all this neuro stuff, right? We always talk about how addiction is a chronic brain disease. You're hearing a lot of these nerve brain medications keep coming into play. Absolutely true. Good association there. So this is a seizure med, it's a pain med, a neuropathic pain med, but it can be used in mild withdrawal. This is not for patients who are super sick in withdrawal, okay? So the ones who are sick and sweaty and altered or seizing, we're not like giving them oral gabapentin. That's not going to do anything. They need the benzos or the phenobarb that we were talking about earlier. But once they're getting better, a lot of you probably have seen patients go home on a Librium taper, right? Can you tell me in the chat, have you ever seen this? A Librium taper or like a Valium prescription diazepam, right? Yeah. So this takes the place of that. And what I love about that is that gabapentin has a far lower risk profile for stopping breathing, and it's less addictive. It can be addictive, but it's less so, far less so than benzodiazepines. So we send people home with Librium prescriptions when they're not withdrawing in front of me, but I showed you that slide earlier. Withdrawal takes days and days and days. It's not a one and done thing for patients. They might still have symptoms. And since the treatment for ongoing alcohol use disorder, naltrexone, doesn't treat withdrawal, they still need something for the withdrawal. I love using gabapentin instead of using a benzodiazepine, and it's a beautiful transitional medication. So on the next slide, we kind of highlighted some of the other things that I love about it. People get fewer cravings during their withdrawal period compared to when they're on benzos. So people who are taking a, say, Librium taper, which is chlordiazepoxide, in case any of you didn't have that memorized, that's the, the generic name for that. Or they take oral Ativan or, Valium, diazepam, whatever. We see fewer cravings if you're using gabapentin instead, which is awesome. Remember that number you need to treat for naltrexone? Anybody remember? It was 12. Guess what it is for this? Nice job, Latoya. This one is 5. 5 patients to reduce heavy drinking days. Really effective medication. Really effective. Like 5 is unheard of, guys. Aspirin in a heart attack is like 42. So 5 is really, really good. These are amazing numbers, really good evidence. And again, it's safer. And then if a patient, by the way, does relapse into alcohol, because we keep talking about this, right? Relapse is a part of the process. It's a part of the process. We should expect it to happen. If you're taking benzodiazepines and then you drink alcohol, that doubles up your risk of respiratory depression, of stopping breathing. Not so with gabapentin. I mean, it does, but it's far less of a risk. So taking gabapentin and then relapsing and drinking, your odds of stopping breathing are less, which is awesome. So many, many reasons that it's safe. It can be, again, a monotherapy option, meaning a one medication only option for patients. It just transitions them right on in. You can take gabapentin and naltrexone. So great, Anne, you just like set me up. So you guys all already knew what I was going to say next, but yeah, you can take them together. And if you look at our California Bridge clinical protocol, that's the recommendation, is that we send patients home with gabapentin and naltrexone as their prescription. So when should you not use gabapentin? On the next slide. If somebody is in severe withdrawal, right? So I mentioned this too. This is not for persons still in the hospital, really sick, or getting admitted to the hospital. This is somebody ready to go home from the hospital. Maybe in the ED, we treated the withdrawal. You look much better now. Or you were admitted to the hospital for a week for your alcohol withdrawal. Now you're on the other side. They have to be in mild, or what we say is refractory withdrawal, the later parts of it, because it does take several days to be all the way normal or back to normal. So that's what this is for. This is the end medicine, not the beginning medicine, for patients who are in withdrawal. And then renal failure. So naltrexone, no bad livers. Gabapentin, no bad kidneys, please. And so that's what we have to pay attention to. Those are the main things. But again, what I love about this is like the bupe for alcohol. It's the bridge to treatment. You start it acutely right in front of you, and then they can go home on it, and then they can stay on it as a maintenance medication for their alcohol use disorder. All right. Yeah, exactly, Roger. Good points about the additive effects for breathing and stuff. Okay. Librium for patients under 60 or no liver respiratory. So you can use Librium or the benzos for anyone, technically on discharge. I don't love it. I don't like writing benzo prescriptions. They scare me. I'll be honest with you. I don't feel comfortable about writing a prescription for benzodiazepine, especially given how much overlap we know there is with mental health and substance use disorder. There is a part of me that feels very uncomfortable writing a 14-day prescription for a benzodiazepine in a patient who also struggles with like depression and alcohol use disorder, right? Like I often feel like I'm setting them up to overdose, which maybe is just me being very conservative and concerned. It's why I love bupe, right? When I do bupe for opioid use disorder, I'm not worried about that patient overdosing on buprenorphine. I love that medicine. And that's now why I love gabapentin in this setting, is that I'm not as worried about a patient overdosing on gabapentin. Can you do it? Yes, I want to be honest. You can overdose on gabapentin, but not like you can overdose on Ativan or Valium or Librium. It's totally different. So I think hopefully for your physicians, by the way, who I know you've been dealing, all of you, getting them on board with the bupe stuff for opioids, this should be a much easier sell. Okay. These are not medicines that they are scared to write prescriptions for. So maybe this is one way that you start to build relationships with some of your more stigma-y or resistant clinicians. Maybe you use this as a bridge to like, hey, look, here's this one with medicines that you're more familiar with and not worried about. And maybe you kind of open the door that way, build a relationship, and then later come back in for the home run with the buprenorphine in an opioid patient. So that's one idea. I do want to talk briefly about, I'm not going to go over all the doses right this moment. They are on the clinical protocol because I really wanted to get the concepts in. So if you ever want to know the doses, go to that California Bridge website and snag them. Okay, harm reduction. This to me is one of the things that our navigators are so incredible at. And it's one of like, you are the linchpin of our programs in so many ways, but one of the ways is that you have this ability to talk to patients and meet them where they're at and have a meaningful conversation, even if they're not ready for medication treatment, right? Can I offer you something today? And these are the list of top pieces of advice for harm reduction in alcohol use disorder. Drink spacers. Anybody know what that is? You ever heard of this before? And it doesn't mean space out your drinks by like an hour. There's no timers involved. But a drink spacer is drink every other, alcohol every other drink. Yeah, exactly. Perfect. So you drink, nice job. You have an alcoholic beverage, and then before you allow yourself to have another, you have a glass of water and you have to finish the water. Now, that doesn't mean homeboy or homegirl's not going to chug that water. Like you're not going to stop them, but hydration is good for them. That's good. And they get more full, and it does slow your pace, right? So if you go alcoholic beverage, non-alcoholic beverage, alcoholic beverage, non, and ideally the non is water, but it could be anything else just to slow your roll a little bit. Remembering to eat. Yeah. Remembering to eat, put something in your stomach. I know there's a lot of like, maybe lived experience for people out there about like how drinking on an empty stomach is much harder on your brain and your cognition and your coordination than if you have eaten, but certainly being sure to eat. The other piece to that, though, remember we talked about this, is patients who have alcohol use disorder are often malnourished and they're really low on vitamins. And so we're encouraging patients like, listen, I'm not even telling you don't, drink. I'm just saying, can you try to get 2 good meals in you every day? Set a timer, set a reminder, like eat something of substance so that you don't have a nasty vitamin deficiency that can cause literally permanent brain damage. Like these are things that we do see in patients with alcohol use disorder. So eat, drink in a safe space, right? Like if you go to a bar in a shady part of your town and you don't know anybody and you get blackout drunk, who knows what's going to happen to you? There are plenty of horrible stories about what can happen to a person, right? Maybe instead you go with a friend. You don't go alone. You go to a bar that you frequent where you know the bartender and they can call you a ride home. Maybe you drink at your house. Maybe you drink at a friend's house, but just drinking in a safe space. I know not all of our patients have that luxury, right? We definitely have unsheltered patients who can't always be in a safe space, but it's worthy of a conversation of where are you when you are drinking to make sure that hopefully other consequences won't happen to you. Obviously not driving, like not operating a motor vehicle after you drink is critical. What is your plan for getting home? Don't drive to the bar and tell yourself you're going to Uber home, right? Uber to the bar. So you have to Uber back or Lyft or taxi. Again, no one's paying me. I don't know what brand. You can take whatever rideshare service you want, but don't drive yourself there, right? Don't give yourself the temptation to drive yourself back. And then realizing that mixing, so a lot of you said polysubstances now becoming super common, more common, which I realize. With alcohol, what I'll tell you is that people with alcoholism tend, this is not 100%, they tend to mainly just use alcohol. People who recreationally use alcohol will mix a lot. The people who have straight up dependent, like chronic alcohol use disorder, a lot of them are pure alcohol. They don't use methamphetamines or opioids, et cetera. But still talking to patients about how doing more than one thing at a time always escalates the risk, right? So alcohol can make you sick and blackout drunk, but alcohol and fentanyl can make you totally pass out and stop breathing and die, right? So just emphasizing to them the mixing and being really cognizant of those additive effects of those substances. And then count your drinks. Have a physical mechanism to keep track. Maybe it's like you wear bracelets on one hand and you move them over, each time you have a drink. Maybe you actually have a check mark. Maybe it's something on your phone, but encouraging patients to keep physical track because sometimes people don't remember, right? How many drinks did you have? I don't even remember. That's part of the problem. We want them to be able to remember. That'd be much better. So in this very last section, I'm actually going to lean on you all to help us fill in. So please participate in the chat as you have been. Dispo planning. Dispo is the medical word for disposition. It just means where you're going to go from here. I don't know why we have a fancy word for this, but examples would be home or to a rehab or to a sober living or to the hospital. Staying in the hospital is a dispo. Dispo is just where are you going? Where are you going? I would love to know, what are some things that guide you as navigators when you see a patient with alcohol use disorder to think about where they should go or what counseling or resources you should offer them? I would love, and you can put them in the chat if you want. I listed a couple of challenges that have been voiced to me by our navigators that might maybe make you lean one way or another, but I would love some of your anecdotal experiences. Yeah, type of insurance is so unfortunate that that's a real thing, right? A lot of the best rehab facilities, best, I'm using that word loosely, but best, quote unquote, make you have private insurance, which is super unrealistic for most of our patients, or you have to pay cash, which is hard. Arjanice, if there is family that is supportive, I think the thought about, are you going home, whatever home is to you, to a supportive environment or not is a critical juncture for me as a clinician. We have like a sober living or a sobering center, really close to my hospital. I feel so fortunate for that. And I'm very aware that like patients with nobody at home, with no one to be there for them, to watch them, to support them, take them to get their medicines, to like be present for them. I have such a low threshold for sending them even for one night to the sobering center, just to be around others who can support you through this. Coming to the ED, it's a terrible day for everyone, right? So to support you through that little 24 to 48 hour period, I love that. Yeah, you can go home, you can get admitted. for sure. Going to rehab, which the word rehab can mean, I think, 18 things, right? 12-step programs. So 12-step programs are definitely, most of the evidence about them come from alcohol. They're very effective. They're not for everyone. I do want to throw that out there, right? Every patient's going to be a little bit different. They're not going to be for everyone, but for some people, they'll tell you that it saved their lives. Patient preference. Thank you for that. We're not the police, right? Patients can choose what they would like. And I think maybe you think that they'd be a great candidate for something that they don't want to go to, right? And so thank you, Matthew, for that. You could suggest it, but if they're like, no way, that's cool. Now you know about it. Maybe next time will be the right time. Yeah, do they have a past history of treatment and how did that go for them? Thank you for that, Tanya. I think like with buprenorphine and opioids, we love to say, have you ever tried it before? Right? Just to kind of cut to the chase. Have you ever been in treatment for alcohol before? Really, really awesome way to get to the bottom of what they might be thinking or wanting or afraid of, or have horrible PTSD memories. And, some of these, there are some horror stories about some centers out there who are really just ripping people off. Thankfully, it's not the majority, but it's real. All right. Let's see what else. Yeah, Emily, I think you're voicing that you have a patient who's had been sober and then relapsed, and you're feeling really stuck trying to help him. I think feeling stuck is probably a very common feeling that a lot of you have. But there are so many good ideas in here. Sobering Center Motel, that sounds cool. I love that. I wish every county had one of those. The Smart Recovery, that's a totally good resource. Your local 12-step program. These are great. So I encourage you to see all of each other's comments in here. Yeah, Sabrina asked about homeless patients and cell phone contact. Two things I'll say to that. Number one, set up an appointment for them to come and see you in the ER, not as an ER patient, but tell them, I'm the Navigator. I'll be here on Thursday at 4. Can you come Thursday at 4? And then I will have a phone ready for you to call, and we'll call some facilities together. Don't be afraid to have the patient come to the front of the ED and say, I'm here to see Chaya. She's the Navigator here in Fresno and I'm supposed to talk to her. Use you as a resource for those patients. And then also there are certain counties that have a program that will give a homeless person a phone. It's not an iPhone, okay, but they'll give them a phone. And so I would look and see if your county, some of the bigger counties have those options. It'd be a totally worthwhile thing for you to look for. Yeah, the unhoused thing. I hear you. I totally hear you. Okay. Thank you all for that. Gosh, I'm reading, some of you are putting your own dreams and wishes in here, and I'm getting choked up. Y'all are going to change the world, and I'm very excited about it. Okay, let's do a couple of takeaways, and then we'll open it to any more questions. So hopefully this really helps emphasize that not all withdrawal is the same, right? Alcohol withdrawal is its own thing. It is a life-threatening medical emergency. There are, though, thank God, medications for alcohol use disorder, just like there are medications for opioid use disorder, but they're not the same medications. Well, one of them is, but let's not do that. They're not the same medications. In AUD specifically, we like oral naltrexone, and we love the elegance of starting somebody who was in withdrawal, who's now better, starting them on gabapentin, having them stay on gabapentin. Really elegant, smooth bridge to treatment right there. If you forget everything, California Bridge has resources. We showed you the screenshot of the one for clinicians. Please print it, give it to everyone, email it to all your doctor team. But there's also, I didn't show it, but there is an alcohol use disorder resource for navigators that talks a little bit more about the screening and stuff. So please take a look at that if you haven't already. Remember that screening, but ESPERT specifically, is a best practice specifically for alcohol use disorder. It's good practice in general, but it has a lot of evidence supporting the specific correlation between doing an ESPERT and alcohol use disorder. So I would definitely lean towards doing that for sure. And then I will hand it back over to Sherry and take other questions.
Great. Thanks, Alicia. This has been so great. Such a wealth of information. This is why we love to have Alicia with us. And again, we want to hear your questions. Chaya just put all of the links that we talked about today in the chat, but we will be sending out a post-event email with the slide deck and the resources we talked about today. So that should be coming in the next few days, if not sooner. So I just, Patty says she's grateful for the sons. Yes, we are too. Several years ago, my daughter was in opioid withdrawal in the hospital. I asked if they had a son on staff, as I had heard about in other states, and they had no idea what I was talking about. So grateful for you. Well, that just makes our heart sing, doesn't it?
Yeah,
That's what it's
my
all
cheeks like
about.
hurt. Yeah, beautiful.
Absolutely. Any other questions for Alicia now that we have her here? Because she's busy. She's doing the clinical training as well as our in-person for next month. So really looking forward. If you want to see Alicia, she will be at our in-person. So any other questions, you guys?
I do see one from Lisa. Lisa said, talking about how language is important, that she was recently in a training about using the word reason instead of risk when talking to clients, because the word reason, to like the reason would be this, not the risk of blah, blah. It can be less triggering, stigmatizing, shaming. What are your thoughts? I use the word risk a lot. When I talk to my patients, I think it's about how you deliver it, right? Like it's all about what you're saying and the context of what you're saying. And if you're like, that is risky behavior, like that's not going to come across very well. Whereas if you're telling somebody like, I just want to make sure that you understand what some of the risks are so that you can stay safe. I don't think that the word risk sounds so nasty. But I love that you brought it up because we didn't talk a lot about language in general. It is, I don't know if you notice, I don't pause often. I know that, but sometimes when I do pause, it's because I'm actually checking my language, even when I'm presenting, because it's very hard to get in the habit of being consistent with your language all the time and saying, person who uses substances, alcohol use disorder instead of alcoholic, right? Person with alcoholism, talking about harm reduction and risks instead of like, just more jarring terms. It takes effort. And I've been working with Bridge now for, oh my God, almost 3 years, which is so exciting. It goes by so fast, but maybe Sherry can back me up here. I'm still always working on listening to myself and like double checking how I'm saying things, because how you come across is so critical. So thank you for raising that point.
John put a good one. It's not what you say at times. Sometimes it's how you say it. 100%, John. I am giving you kudos to that saying, because it depends if you relay that empathy and that compassion and that motivational interviewing that we so much give training on. The words come out as, I'm here to support you. It's not judgment. So definitely, I think how you say it is 100% of the message. Concern should be a good replacement for risk. What concerns you have about your use, which lets them think about risks in a compassionate sense. That's a good suggestion. And like I said, I think it's on how we're talking to the patients. A lot of you guys are the role models. For the hospital staff, just because they haven't been trained, they're not educated. So I think relaying a safe, compassionate environment, however you're doing that, is going to, the patient is going to reap the rewards, and the staff is going to see it. So just remember, however you're saying it, just choose to be the role model, because we know you guys are. Nobody else is doing this work. So that's what I encourage. And words, we are sensitive to words. We know that words matter. A lot of you guys have already started your campaigns with these type of words, and it takes time for everybody to adjust. So again, harm reduction, meet everybody where they're at, including the words. So just continue to be the role model is what I would say, no matter how you're talking to the patients, because I know you guys are the role models.
Exactly. And I think it's that, maybe it was Maya Angelou, Eleanor Roosevelt, some cool chick who said, no one's ever going to remember what you said, but they'll remember how you made them feel. Right. I think leading with intention is so important. And so don't get hung up on your words necessarily. I think for me, what has helped me a lot is I always offer an opening, like I have like a 1-sentence preamble where I always say, I'm going to bring up some touchy stuff because I don't care in a sense that you use substances. Like I think you should be able to make your own choices. What I do really care about is that you stay healthy and well. And I just want to make sure you have all the information that you need to make those choices. That way I've like framed what I'm about to say in case I like stumble on my words or say something kind of silly, or maybe in a way like that would be triggering to them. But I've made it clear in the beginning, like, look, I'm a doctor. I'm not going to say, please go use drugs, but I also acknowledge that, a lot of people use drugs and you might use drugs, but can we talk about how you're going to stay alive and healthy? I just want to make sure you know a couple of things. And then I pick, I think 3. I try not to teach patients more than 3 things at a time, because hopefully they'll remember one of the 3 things that I teach them. But that's sort of I always try to set the stage for myself, realizing that you don't know what it is you're going to say that might be the phrase they didn't want to hear. Right. But if they understand where you're coming from, it's really helpful. And same with the doctors. I'm going to offer this to you. Turn off the recording. Just joking. But if, doctors are, we're a special breed. Listen, we worked really hard to get where we are. I don't know if you know that, but the amount of like school and hours and all that stuff is, it's a lot. And so it can be very, offensive is not the right word, but we get defensive when people come try to tell us what to do, not because we're like proud and arrogant. I think that is how it gets construed sometimes, but it's actually because we have devoted so much of our life to trying to do this job well, that when someone kind of comes up and is like, you're doing it wrong, or you should be doing this thing, there's a piece of us that's always like, excuse me. It's natural. And so I think approaching doctors or any staff, for you as a navigator, I know that some of you have told me before, it's really hard. If you go to that clinician and say, hey, I noticed that, first of all, I would always say, Dr. So-and-so, is this a good time? Because sometimes it's the wrong time. Never interrupt without asking if it's a good time. They might be doing something very critical. They look like they're typing, but they're like really thinking about something. So be cognizant of that. Is this a good time? I saw the patient in room boba, has alcohol use disorder. Do you mind if I see them? Or, hey, I was chatting with that patient. I was thinking they might be a really good candidate for something like Naltrexone. I don't know if you're super familiar with that, but like California Bridge has a cool protocol they released. I can show it to you, but I just thought they might be a good candidate. What do you think? And I think if you approach it that way, where it's about the patient and you have this idea and you're wondering what they think about your idea, right? That's a much better received thing than, why aren't we sending this person home with Naltrexone? Like, obviously they should be going, and you're like, "Wah." So that's my advice to you, is always lead with intention, keep it about your patient and the compassion that we all know you have.
Thank you so much. Thank you so much, Dr. Gonzalez. And I know Coco had some questions about phenobarb treatment. I'm going to have Alicia's email on the last slide. So you might want to give her an email for that question since we're running out of time. Once again, you were awesome and amazing. Our navigators love you. We love you. And again, if you want to see Alicia, she'll be in the in-person. So thanks again. And we have our Bridge Academy. We just want to remind everybody that is a tool. It has all our past trainings, including our Sun 101 training and some of our recent navigator focused trainings, and you can get KDAP CEUs. So we want you to be aware, and you can find that on the Navigator landing page. And again, we're promoting our Building and Strengthening Your Bridge Navigator program. That's going to be in Irvine on the 21st. Please sign up. We want to make sure we have enough room for you. So please sign up as soon as possible. As always, you can always email anytime, but we are on social media. Contact our mentors at mentors@cabridge.org. And here is Alicia's email if you need to contact her with more questions, or if you need a mentor, you can always email me as well. We're all here for you to support you. The training is free. I saw somebody in the chat. Is there a cost to that? It is completely free. So you need to come. You can get some breakfast, some lunch, and some great information. We're going over a bunch of things. We just had the Oakland the Oakland event, and it was well attended and people can give great feedback. It was just amazing just for us to get together
Yeah.
and network with other navigators. It's truly amazing. So we enjoyed our time today with Dr. Gonzalez, and we hope to have you back soon.
Oh,
Um,
I love it. Anytime. You're
all
on it.
right, guys, until next time, thank you. And thanks for all the work you're doing out there. Bye-bye.
Bye.